Start. So good afternoon and a very warm welcome to you all, and thank you for joining us for our second My Awareness Month webinar. My name's Tracy and I'm one of the National Support Coordinators for My Aware, and I'll be hosting today's session. Laura and Vicky from the support team are working away in the background to make sure everything runs smoothly for us, so thank you both. And I'm delighted to say that we are joined by three of our specialist nurses today, who you will meet during the session. The specialist nurses have been treating patients with myasthenia for many years collectively, and today they will be covering aspects of fatigue, medication, talking about breathing issues, and explaining what a crisis is. We are very excited to be learning from today, so thank you for taking time out of your busy schedules to offer support to so many of our members, and many of whom don't have access to a specialist nurse, so this is a real treat for us. Before we hand over to the nurses, just a couple of things to point out. These sessions run slightly differently to our Zoom sessions, so your cameras and microphones will remain off through the session. We are also recording the session. Should you have any hearing concerns, you can enable closed captions via the CC button at the bottom of your screen, where you can also change the language if you would like to. I will now hand over to the specialist nurses. I'll be turning my camera off and I will put back later at the end of the session. So ladies, the stage is yours. And Georgiana, I think you're up first. So it's over to you.
Thank you, Tracy, and thank you for having me today. My name is Georgiana. I'm the clinical nurse specialist based at Queen Square, and we had a few questions coming through for medication, so this is what I am going to talk about today. So I think it's important to start with saying when you see your neurologist and, there's a plan of starting your medication, it's important to understand the side effects that you might experience on these treatments, and also have questions about, the duration of the treatment. How long are you going to be on the medication for? Because a lot of questions were kind of long-term effects, side effects of all of the different medications, and there are quite a few that I'm going to try and talk about today. But it's important that before you go on any tablet, you make an informed decision about these medications that you go on. So I'll start with the most common medication and how we escalate the treatment if there's no response. So the most common one is pyridostigmine, and you will all know it. It's we call it also Mestinon, and that is purely symptom control. So it doesn't affect the underlying, pathology of antibody production. It starts working fairly quickly. It works within 20 to 30 minutes, and it doesn't last long. It will last for about 3 to 4 hours, and you'll probably feel when it's wearing off. So your symptoms will start coming back. The maximum dose, so the tablets come in 60 milligram tablets, and usually the maximum dose that we advise is 6 times a day. We don't advise to take any more than that because it causes quite a few side effects, such as diarrhea, abdominal cramps. You might get some salivation, and it might make things difficult, like you going outside and do your things every day. There are a medication that I'm going to talk about after that counteracts the side effects from it. But in general, if you do notice the side effects from the pyridostigmine, we usually just advise to reduce the dose and reduce it, go to 4 times a day, let's say. Sometimes people might feel like in the morning they need a little bit of energy to kind of get up and go on with their day. So you can adjust the medication. You can take 2 tablets in the morning as long as the total doesn't exceed the maximum dose, which would be 360 milligrams in total. I think there was also questions about is there an alternative to that medication? There is no alternative to that. We used to have a tablet called neostigmine, but it's not really available anymore. So pretty much a lot of our patients on the pyridostigmine. The medication that can counteract the side effects, the most common one that we use is called propanthelin. And there was a shortage, and I think it's really hasn't fully resolved yet. And there was also questions about when should you take the propanthelin to counteract the side effects from the pyridostigmine. So we advise to take the pyridostigmine 30 minutes after take the propanthelin. I think Yes, and the propanthenol, we would say maximum 3 times a day. So if you don't take pyridostigmine, don't take propanthenol. There's not really a point. Sometimes people find that the doctors start them on both of the tablets together. You might not need it unless you actually do get side effects from the pyridostigmine. Then the next treatment that we have is prednisolone, and most of our patients will be on that. It's the steroids, and it suppresses your immune system. There are a lot of side effects from it. It can cause thinning of the bones. It can cause steroid-induced diabetes. It can put you at risk of infections. So even though it is a brilliant medication, it's really not the best to be on long term. There are each patient will have, the maximum dose that they will respond to, and their symptoms will resolve. But we do try, as soon as you get your symptoms under control with the prednisolone, we do try to start reducing the dose fairly quickly. There is really not a specific dose that people will develop symptoms, side effects. So it's not really for me to say that if you take 10 milligrams of prednisolone, you will develop side effects from it. Some patients will develop side effects on 10 milligrams, others will develop on 30 milligrams. So it's not really like a specific dose that causes the side effects. If you are on the prednisolone for a very, very long time, you still have symptoms and you haven't been able to reduce it at all, and you're worried that it's causing the long-term side effects, then the next step to the treatment would be what we call a steroid-sparing agent. And these medications are 3 different medications. We use most commonly 3, and there are others that we don't use as often. The first one is called azathioprine. And then we have mycophenolate. You might have heard also of methotrexate. So these are the most common ones that we use. The main goal of these tablets is for you to be able to reduce the prednisolone. So again, they are suppressing your immune system. They are putting you at risk of having infections, but compared to the side effects that you can get from the prednisolone, you really have to think of weighing the risks and the benefits from that. These medications require a lot of monitoring. They require very frequent blood tests. Usually we start with weekly blood tests. And they can cause your white cells to go really, really low, putting you, as I said, at risk of infections. And it can also cause abnormalities with your liver. There's also some side effects, mainly for the mycophenolate and the azathioprine. There's a higher risk of patients, if patients take it for a very, very long time, there's a high risk of getting some kind of cancers. So with the azathioprine, it's mostly associated with some benign skin cancers. And that's why we advise, if you are on azathioprine, you should wear a high factor sunscreen, wear nice big hat and everything. Don't stay in the sun, don't get sunburns. With mycophenolate, the high risk of cancers is mostly with some blood cancers. And methotrexate, also some skin cancers, and there's can cause some lung abnormalities as well. So we need to keep an eye with x-rays and things like that. I'm trying to think if there's anything else. The azathioprine, you need to have a blood test before you go on it, and that's for us to see how well you process the azathioprine. Because if you cannot process it well enough, then you can develop liver abnormalities way easier. And if you are a woman of childbearing age, azathioprine is basically the only option that you have. The other medications are really not suitable for pregnancy or breastfeeding. There is really not a rule of how long you need to stay on the medications for. We say that if you are in remission while on these medications, you are in what we call a pharmacological remission. And the only way for us to know if the symptoms will come back, is for you to be off the medications, which we don't really advise. If you've been on them for many, many years and nothing has changed in your symptoms, nothing has changed in your myasthenia, then you can have a discussion with your neurologist to kind of slowly wean them off. But we do the slowly wean because symptoms might come back at any point. And always keep a close touch with your neurologist as well while you do that. Don't try to wean them off yourself. You might have a relapse. So yeah, just be very, very careful. And while you are on these medications, like I said, you need to keep having your blood tests. It's very dangerous for you to be on any of those three if you don't have blood tests done. Other medications that we use, so these are most for emergency situations. So intravenous immunoglobulin or IVIG. It's really the criteria for you to receive IVIG, unfortunately, are very strict. And the decision is completely out of our hands, and the team that usually requests the IVIG doesn't have a say in the patient receiving the IVIG. We put a request forward to a panel of different people, so pharmacists, nurses, and neurologists, and they make the decision for that. So based on the symptoms that you have and how bad the myasthenia is, they will make the decision if you can have IVIG or not. And most of the times, if you are at home and your symptoms are getting worse, but you're managing at home, most of the times you will not be eligible for IVIG. If you need to come to the hospital because you're really weak and you cannot breathe, you cannot swallow, then yes, at that time, probably in A&E, whoever sees you, you'll be eligible for IVIG. Other emergency treatments, which is not exactly medication, but we have plasma exchange. Again, it is for emergency situations or until we get things stable on another medication, just because it's a bit easier to kind of arrange it in the hospital. And these days we do it peripherally. You don't need to have like a central line for that. I think there was a question about IVIG and immunosuppression or high risk of infection. So IVIG is not really immunosuppression. If you do get lots of infections while on IVIG, you should look into other reasons for that. So any other like medication that you're taking, they should check your blood test and make sure that everything is okay. There is as well, we have rituximab infusion, which is a medication that suppresses your B cells. This medication is suitable for both RMASC patients and for acetylcholine receptor antibody patients. It does also carry some risks. You don't get like a good response from the vaccines. You are fairly immunosuppressed if you take rituximab. Once you have rituximab, we cannot take it out of your system. It's an infusion, and there's basically no way back. As if you were taking like a tablet, you can stop it and things will go back to normal. With rituximab, you have to wait for months and months before it goes out of your system. There's a small risk of this thing that's called PML, which is a progressive leukoencephalopathy. Sorry, it's a very long name. Which is a very rare inflammation of your brain. And it's very scary. When we usually say to our patients, everyone is very worried. It is a very, very small risk. But as with everything, we have to say it. You have to, like I said in the beginning, you have to know what you're signing up for, what you're saying yes to. But I can tell you that it's a very small risk. And in the literature, there's a handful of reports of people that had myasthenia and received rituximab and got this PML. There's also, as you might know, there's efgartigimod, which is currently going through the NICE process. So I don't have an update on that. And there's really kind of until we have the decision from NICE, there's nothing really much else that we can discuss about. And there are some other medications that are waiting to go through NICE. I think they are going kind of in 2024. But again, until they do get a positive decision from NICE, it's not really something that we can offer in the NHS. So we have to wait and see about that. I think that is all from me about the medications. And now I'll hand over to Sarah. Thank you.
Hi, thanks, Georgiana. That was really interesting. I'm Sarah. I'm Sarah Mason. I'm the neuromuscular nurse based in Belfast, although I cover the whole of the province. And I'm going to just talk to you this morning or this afternoon about fatigue management and exercise. There was a lot of questions, so I've tried to sort of bring things together as best I can. So I apologise if I haven't answered all the questions. And just so that you're aware, it's more general stuff. I'm going to talk about more practical things. Rather, there's a very good, earlier this month, Dr. Chana Hewamadama, I think his name is, did a webinar for MyAware, which is on the website, which gives a bit more technical background, research, all those sorts of lovely things that some people like to listen to, and case studies. So that's really interesting. I've also given the MyAware some links in terms of managing fatigue, and also information for afterwards. So fatigue is very common in myasthenia. About 80% of people, that's about 4 to 5 patients, report fatigue that affects them every day. And it seems generally to be worse when people who have generalized myasthenia than those people who are in drug-induced remission or who have ocular myasthenia. Fatigue is different to muscle weakness. I'm just going to explain a little bit about, so a definition of fatigue is an overwhelming sense of tiredness, a lack of energy, and feelings of exhaustion. Muscle weakness that's associated with myasthenia is not fatigue. And I think this is something that patients often get confused about a lot, particularly when doctors and maybe nurses talk about fatigability. Fatigability is observing an action, a repeated action of a muscle, and watching that muscle get weaker. So whenever the doctors are asking you to blink your eyes 10 times, or pump your arm in the air 10 times, or lift your leg up 10 times, they're looking to see, does that get weaker over that short period of time? Things you might notice it in yourself, if you were out pegging out the washing, your arms might start to get more tired as you go on, or if you're drying your hair or straightening your hair, and after a brief rest, the muscle comes back and is strong again. So I didn't know this before I listened to Dr. Chana's webinar, but that's known as peripheral fatigue. And what generally people talk about is chronic fatigue, this is something that lasts usually about more than 6 months and affects patients' function and their quality of life, their ability to do normal activities of daily living. And you have symptoms of no energy, tiredness, and that's not related to muscle weakness or pain. And this is known as central fatigue. Who knew there were different types of fatigue? But this is known as central fatigue. And it is not unique to myasthenia. It's the same fatigue as in many, many other long-term chronic conditions. Varies in symptoms and how it impacts on your activities of daily living. And generally, increasing your medications will not help this type of fatigue. Rest will help if it's myasthenia related, and if your symptoms are active, but generally also rest may not also help the type of fatigue you're experiencing. So causes of fatigue then, there's quite a lot, and that generally aren't necessarily related specifically to myasthenia. Poor sleep hygiene and poor sleep patterns, not getting sleep at the right time of the day, not having the right circadian rhythm, or if you're not getting if you've got issues with sleep apnea or breathing difficulties at night time. Pain can be a big issue in terms of fatigue, as can low mood, anxiety, depression, poor diet and hydration. And actually from listening to some of the facts and some of the research shows that depression and low mood are one of the greatest risk factors for having generalized central fatigue. The problem in myasthenia is that our patients experience some muscle weakness, and whenever you have muscle weakness, the brain generally tells the body to do less, and then the body feeds back that it's tired to the brain, and then we do less and less. It's called missignaling, and people can become sluggish and fatigued, and deconditioned then, and we can even breathe faster if we do undertake any exercise at all, because the muscles are feeling fatigued. It becomes a vicious circle. So the less exercise you take, the more your brain thinks that you're fatigued, and it goes round in a circle. So the generally speaking, the lower the level of activity we have, the increased fatigue that's experienced, and that's not just for people with myasthenia. That's generally in terms of the population. So how do you manage fatigue? It really requires a holistic approach. And they talk about the 3 Ps, but I think there's probably 4 Ps. Physio is 1 P, and it's really important. Ideally, a neurophysiotherapist, if you can access a physiotherapist, with somebody that can understand a little bit about the myasthenia, but give you advice on deconditioning and fatigue and how to manage that. And most physios should be able to manage some of that. The other P's then they talk about are planning. So planning ahead, organize your activities, think what it is you want to do, what you most like doing, what you need to do. And if you want to shower and this makes you tired, then make a brief time at the end of that shower to have a rest, or plan your activities so that if showering and getting dressed, breakfast takes it out, if you have a break late morning and then carry on with your activities in the afternoon. Prioritizing is the other P, so dealing with the tasks that are most important to you. Generally, we tend to advise people, do the things that you enjoy doing. If you can get somebody else to go and do your shopping or do your cleaning or do your ironing, do it. If people are offering to help, allow them to help, delegate your tasks, but do the things that you enjoy and be kind to yourself. And then it's about spacing. Pacing is the third piece. So spacing out your jobs and building up your stamina, not going hell for leather. I'm going to clean this house all at one go. We could do a bit of a room, or, do bits and pieces slowly. And then this isn't a P, this is a D, delegate. So get other people to help you out. There's nothing wrong with that. And people, particularly if they can see that it's helping you in the long run. If your myasthenia is active, then rest periods are important, but you've got to remember that too much rest or sleep in the afternoon can disrupt your normal sleep pattern. So if you can't get a good sleep at nighttime, but you're sleeping all day, then you need to sort of look at managing that. There's another good thing on managing sleep by a gentleman called Kaiser Permanente, and it's about sleep hygiene and how you manage your own sleep. It's available widely on the internet. And any activity will improve your mood. So walking, stretching, all those things improve your mood. It doesn't need to be intense type of activity. People ask what sort of exercise should they do. It really has to be down to the person. If you're a gym person and you've gone to the gym, then of course you do that. But if you're not, certainly don't be running off to the gym and doing, 5 Les Mills or RPM classes all at one go, because you'll be knackered just like the rest of us were. Little things can make a big difference. So get off the bus to stop earlier, or park your car that bit further away, or go for a short walk. Maybe set a timer for 5 minutes once an hour to have a little walk. So it really depends on the person. And again, that's why physio can be particularly helpful in terms of giving you strategies to build up. So as I say, gentle walks, swimming, regular stretchings. When you start exercising, everybody finds it hard, and that is completely normal. It's normal to be a bit achy or a bit sore the next day. It's just the muscles will recondition and you'll build your stamina up over time. So you aim for low, moderate exercise, and you should be able to talk throughout. So again, starting small, achievable goals, and then build on this. And increasing your activity will mean that you can do more and more and feel better. Again, consider healthy nutrition. So if you're overweight, you're likely to feel chronically tired. You may have some sleep apnea, which may be affecting things. So reducing the weight can help with the sleep and improve activity. Ensuring you're well hydrated. Being dehydrated can make us feel tired. Good sleep hygiene, as I've mentioned. Avoid the phone at nighttime. Switch off the TV. Consider reading. Avoid caffeine. I think those are the kind of information we could all take home with us. And I'm sure you know a lot of this information. I feel like I'm going through stuff that you already know, but it is really those simple things. Look at relaxation techniques, mindfulness, meditation, and how you manage your stress and stressful situations. There is no one size, unfortunately, that fits all. And it's about working within your own limitations and your own ability. I think the take-home message is that exercise with myasthenia is safe if it's tailor-made, and generally a sedentary life will increase poor health. So getting up and getting a bit active and working with the myasthenia as opposed to letting the myasthenia or the tiredness work against you. So I don't think I have anything else to add. MyAware, I know, haven't got a specific advice on this, but it's something that we're working on now, linking in with OT physios and some of the medics. So that should be on their website soon. I am going to hand over to Jude now. That's me done. So she'll do another little section, then I'll see you again later on.
Thanks, Sarah. And who knew about peripheral and central fatigue? So I've learned something new as well. That's always a good thing. So hello to everybody. I'm Jude. I'm going to start off by talking a bit about breathing, and then I'm going to move on to talk a little bit about crisis management. So it's really hard to find like exact data just about breathing, but we do know that many people, somewhere between, we think 60 to 80%, actually report breathlessness or breathing problems as one of the most disabling problems, along with fatigue, which Sarah's just talked about. A third of all people who experience relapses in their myasthenia, which present with sort of breathing problems, are caused by a chest infection or a respiratory tract infection. Breathing problems are more prevalent in people who've got MuSK antibodies because there tends to be a frequency of having weakness of the respiratory muscles. So the reasons that people do get problems with their breathing, it's more in very more severe cases of myasthenia. It's because you can get weakness of the diaphragm muscles, but also other respiratory muscles. So the intercostal muscles, which are the ones between our ribs, and accessory muscles. They're muscles that aren't usually involved in normal breathing, but when breathing becomes hard, they take over. Also, people who have problems, you'll probably know the word bulbar sort of symptoms. So either weakness in their laryngeal muscles, so their voice box, or their pharyngeal, which is the part that connects your nose to your mouth, down into your stomach. If you get weakness around there, it can have an indirect impact on your breathing, because it can then lead to problems like aspiration, where normally when you have a drink or you eat something, there's a mechanism that closes your airway off, so it just goes down the right tube. And if that's weak, then often, or sometimes the case can be that food or liquid goes down into your lungs instead. And that can then lead to infections and pneumonia and an impaired sort of capacity to be able to breathe properly. There's also a number of aspects of myasthenia. So just the generalized weakness, the being autoimmune, but also long-term immune suppression treatment, which may make you more at risk of getting chest infections and the risk of having a worse chest infection or any complications. There is some sort of talk about whether people with myasthenia, some people may develop what we call dysfunctional breathing. And it's for the very small proportion of people who've had a MG crisis at some point, which I will talk about a bit later, understandably raises the long-term anxiety of, is that going to happen again? And I think it's often it's one of the symptoms that a lot of people do worry about. And I know that I get lots of contact about, I am breathless, what do I do? So one of the key things I think we want to say is there are many causes of breathlessness. It's not a specific marker for muscle weakness. there can be a number of things. So lung conditions, so if people have got chronic pulmonary disease, emphysema, if they've got heart conditions such as heart failure, things like lupus or diabetes can indirectly influence your lung function. Obstructive sleep apnea, anxiety. There is a possible association with asthma and an increased risk in myasthenia. There were quite a few questions that we got through about the use of inhalers. And so it's just trying to stress that those inhalers, whilst they work really well for asthma, they won't help any myasthenia-related breathlessness. How they work is they work directly on the airways, so they open up your airways so that more oxygen can get through. Whereas in myasthenia, if it's the muscles that are weak that's causing the difficulty with breathing, then they're not really going to help. But also you need to consider the effect of all the treatments on myasthenia. So I'm sure many of you are on steroids, as you have probably lived through a lot of the side effects of knowing that they can cause you to put on weight. There is an increased chance of getting obstructive sleep apnea, heart failure. If you're on immune suppression treatment, that increases the risk of chest infections. It's a well-known fact, and understandably, that a lot of myasthenia patients tend to exercise less. You know, if you're fatigued, whether that's generalized or peripheral fatigue, you know, you're not going to be as tempted to be getting up and doing some more exercise. So you do quite quickly, and like Sarah was saying there, that actually I think we recognize as health professionals, people decondition quickly and then it's quite hard to get back to a previous level. But often as a result of that deconditioning, you can develop breathlessness that's not actually related to the muscle weakness. Breathing can then become a bit shallow. There's a tendency to then hyperventilate because you're not getting enough breath in. Anxiety then has a significant part in that. And then we get into a bit of a catch-22. I can't breathe. You get more anxious. You start breathing in a really bad way. And then it becomes this pattern of abnormal breathing. So there are lots of different triggers. I'm sure many of you will know the triggers anyway that are more likely to cause a relapse. I'll just go through them briefly. So things like infections, particularly a chest infection, is obviously more likely to make your breathing worse. But any infection, any other illness, surgery, new medications. For women, it can be hormonal changes. The heat. So I don't know how many of you have survived over the last week I don't think Sarah's had the heat, but in the south of England, we've had some scorching temperatures. So I'm sure many of you have struggled with that. And that can often make your symptoms worse. And particularly if you do have a tendency to have difficulty with breathing, that could make it worse. So the warning signs or the symptoms to really be looking for. It's a new shortness of breath without another cause. So is it that you've got a chest infection? Is it, what's happened? Or is it that you've always been a little bit short of breath, but actually it's got increasingly worse for no apparent reason? Breathing often becomes quite rapid. So it can get quite quick, but quite shallow or laboured. So you don't feel like you're getting a really full breath, or it's quite hard to take a big breath. People can develop what's called paradoxical breathing. So whereas normally when you take a breath in, your chest and your abdomen, they go in. And what happens is in paradoxical breathing, it's the opposite. So it's the complete opposite. So your chest and your wall would go out. So that can often be a sign of respiratory distress. A lot of people find that they can't lie flat, or they get very breathless when lying flat. The technical term is orthopnea, and that can show that there is sometimes that's weakness that you're getting in the diaphragm. To be able to speak as I'm speaking now, we need to have a good lung capacity and lung function. And actually, when your muscles aren't working well and it's starting to cause weakness, people find that then they can't speak for more than a few words without needing to stop and have a rest. Or they might find that their voice gets very weak. There is a correlation sometimes with neck weakness, so people have a weakness in the neck flexion. One of the things it doesn't cause is wheezing, and it shouldn't cause phlegm or like a regular phlegm or mucus, although bearing in mind that excessive use of pyridostigmine sometimes can cause that. But obviously, if you've got a chest infection or if you've got asthma, it could be that that's what's causing these other symptoms. So the best way of sort of avoiding any problems with your breathing is avoiding any of the potential triggers, reducing your risk of infections as you can, taking the medication as prescribed. I know it probably seems obvious, but there are lots of people who, despite our advice, might want to do their own thing. But speak to your GP, speak to any other teams. If you're known to a respiratory service, or you've got an asthma nurse, or you've been diagnosed with heart failure, make sure that you're in regular contact with them. Or if you have problems with sleep, or if there are any concerns, discuss that with your team, whether you need to be referred to a sleep clinic, because we know that if you're not breathing at night, there are things that can help. But actually, by making sure that all of those conditions are well treated, it reduces the risk of it then having an impact on your myasthenia. Sleeping at night or during the day, as long as it's not too much, Sarah, the sleep position. So probably the better position to sleep in is either side lying or semi-upright. So you can either use a pillow, extra pillows, bearing in mind that when you use extra pillows, sometimes they can push your neck forward too much and then it can constrict on your throat. So sometimes you can get wedges that you can, like wedge pillows, or I've even heard one of our neurologists talking about putting bricks under the end of your bed. But I don't know, it seems a bit extreme to me, but that maybe is a way. But that can also help with not only breathing, but it can also help with things like with asthma, but with reflux. There are some people, normally those who either have had a crisis and it's recognized that they do have very poor diaphragm and respiratory weakness, or they've got sleep apnea. They may require non-invasive ventilation, so things like BiPAP or CPAP. We had a few questions about pulse oximetry, so oxygen saturation machines. And I think this has come up sort of time and time again. They're really useful for lots of conditions such as COPD, but actually it's not recommended for use in myasthenia. The reason being is because they don't give a good indicator of respiratory strength in myasthenia. It can really give a full sense of security because oxygen levels often don't drop until a person in myasthenia is already in respiratory failure. So I think we've probably all heard it. I know, Georgiana, we've talked about it before, but when on the wards that the nurses will say to us, oh, but their oxygen sats are fine. And we're like, we know that. We expect them to be. The day that their oxygen sats low is, we're probably already really quite worried at that point. So whilst they are good to have, I definitely wouldn't be recommending going out and buying one, because from a myasthenia point of view, it's not going to be a good indicator. Something else that can be done, and you don't need to spend any money, is single breath counting. So in clinics or in hospital, I'm sure many of you have done spirometry, which is one of the measurements we can look at how much your lung capacity is. So it's called forced vital capacity. When often we're talking to people on the phone, or people want to know how they can try and manage things at home, you don't have a machine. You definitely don't need to go out and buy one, but just being able to count how much you can do in one single out breath. So what I would normally say to someone on the phone is take a deep breath in, and then in that one breath you need to be counting out. So 1, 2, 3, 4, 5, 6, 7. Just keep going. And ideally, you want to be getting over 20. Anything, it fluctuates anywhere between 15 and 20. I would normally say sort of 15 typically correlates with a low forced vital capacity. And that's showing that there are signs of muscle weakness. So just, again, thinking about how else you can try and either improve your lung function and your breathing, or try and prevent things from getting worse. So, there are lots of studies now that are showing exercising is safe in myasthenia. We know generally exercising helps not only improve muscle strength, but daily function. There's lots of evidence say it improves your overall fitness, it improves sleep, it improves mood, can help control weight gain, blood pressure, blood sugar, even protect your bone health. So really important if you can try and incorporate. Again, doesn't necessarily need to be a Les Mills class, but it could be just a gentle walk or some basic stretching exercises. Just trying to incorporate it into your day-to-day life. There have been studies that shown that after some general exercise programs, your force vital capacity, so your breathing capacity, is improved, and it can also really help to regulate your breathing pattern. There are loads of resources online where you can look at things, controlled breathing exercises. So there's one known thing called box breathing, where you breathe in for 4, breathe out for 4, breathe in for 4, breathe out for 4, and you can increase it, breathe in for 6, out for 6. Diaphragmatic breathing, where you just concentrate on, hand on the stomach and your hand on your chest. And what you're wanting is, as you take a breath in, it should be your stomach that rises and goes down again, rather than your chest. Because if it's coming from your chest, you're not taking a full deep breath. So it's all of these things. It's not something you do once and suddenly it all improves. It takes practice, and it takes a long time to get used to it. But they also help controlling anxiety. And again, like I said before, it's that catch-22. You can't breathe very well, you get anxious, your breathing gets worse. So actually trying to have all of these as a bit of a toolkit, so that when you notice that you're starting to get a bit anxious, actually look at what's happening with your breathing and how can I try and concentrate. Even just sitting with your eyes closed and concentrating on breathing in through your nose and out through your mouth, and just concentrating on the breathing sometimes is enough just to help. But there are also exercises you can do to improve your posture, because that can help with again, how much your lungs can expand. If you have a tendency to what we call kyphosis, where you are more rounded shoulders and bent over, that obviously means your lungs can't expand as well, but also will have an impact on your swallowing and your speaking muscles. So I think, going with what Sarah was saying, sort of the key points from an exercise is don't overdo it, especially if you're going through a relapse at the moment. Exercise at the best time of day for you. If you're someone who takes pyridostigmine, take that before you do your exercise. Do a mix of aerobic exercise, resistance training, and stop sort of before breathing or the fatigue kicks in. So if you have any concerns about your breathing, contact, if you're lucky enough to have a nurse specialist that you can, or a neurologist, either secretary or however they work, or your GP. If you have any concerns about you're changing your breathing pattern or worsening of that breathing, because often they need to be ruling out as well, is this myasthenia related, or is this as a result of chest infection that needs treating. So in the worst case, if they feel that you need to be admitted to hospital, they will often do lots of different tests. So things like chest x-rays to see whether there's infection there. They might do an echocardiogram, which is a scan of your heart, just to see if there's a buildup of fluid or heart failure that's causing the breathlessness. And again, they'll do the spirometry, so your breathing tests. Treatment for breathing, it's treating the underlying cause or the contributing factor. So if it is a chest infection, if it's a heart failure or a COPD, you need treatment for that first. If we do think it's to do with the myasthenia, then the symptomatic treatment would be with pyridostigmine, because that will help to improve respiratory muscle strength. It's worth noting that pyridostigmine is, you do get dose-related side effects. So as Georgiana was saying earlier, that if you have some of the side effects, you would reduce your dose. It can increase your risk of secretions as well in your respiratory tract. So then you can get a build-up more of mucus, which can impair your breathing, and then more risk of infection. Oxygen can be quite useful, but it doesn't alleviate respiratory distress in myasthenia patients. So I think the key thing is knowing when to report it, and people get breathless for lots of different reasons, and sometimes it's looking at is there an underlying other cause of this that's not just my myasthenia. Okay, that's going to lead me to talk about crisis. I just need a drink, dry mouth, sorry. Okay, understandably, this is probably the most frightening thing for all of you. So you're diagnosed with myasthenia, this rare condition no one's ever heard of. It might have taken you 2 years to even get a diagnosis. And then you're told, So there's a risk that you could have a crisis and end up in ITU on a ventilator. Understandably, panic sets in. So what I want to do is try and just distinguish the difference between a crisis and a relapse. So a lot of people may use those words interchangeably, but they're two different things. So we know that myasthenia follows this sort of pattern where your symptoms can be quite poorly controlled. We can then hopefully get you into remission. That's the aim of what we all want to do, is get you into remission, so as in no symptoms. But there is always a risk of a relapse or exacerbation or flare-up of your symptoms. And like I said, there's the triggers that I talked about earlier on that can cause that, or sometimes even when you're reduced, like if you're reducing your immune suppression, so say your steroid dose is going down, and it may be that you're getting more ptosis, so droopy eyelids, or your double visions come back, or you're starting to notice that chewing's a little bit more of an effort, or your arms are getting a little bit weaker. That's more a relapse that you're having, or a flare-up, as opposed to a crisis. So the definition of a myasthenia crisis is a life-threatening exacerbation. It's rapid worsening of the myasthenic weakness, and it's typically respiratory and or bulbar muscles, so your lung and your breathing and sort of mouth and throat and mouth muscles. So it can result in obstruction in your airway with severe difficulty in swallowing or inability to swallow, which can then lead to respiratory failure. Ultimately, that requires them to put to intubate you, to put a tube into your airway and then help to keep your lungs going through ventilation. So often it's the first presentation of a lot of people in myasthenia. So they didn't realise they had myasthenia, and it's not until they are in intensive care that someone realises that this is what's been going on. So most myasthenia crises occur in the first few years after diagnosis, when the disease is in its most active phase. And that's when we say active phase, that's when you'll get the most sort of fluctuations, the most up and downs, but also the most severe symptoms. It's thought that around 10 to 20% of people will experience at least one myasthenia crisis. So actually, even though we all drill home crisis, you've got to be aware of a crisis, that's actually quite a small percentage. Maybe that's easier for me to say because I'm not the one with myasthenia, but 10 to 20% will have one crisis. And the majority of those are at that first point, when first manifestation of the disease. So LEMS patients, I know you have lots of other things to deal with, but we wouldn't expect you to ever have a crisis. You are more at risk if you have a greater severity to a diagnosis. So when you are diagnosed, you have involvement of lots of the different muscles. You already have problems with your breathing, your swallowing, your neck and your arms, as well as eyes. If you have a thymoma, you're more at risk, and also a MuSK-positive MG patients. As I said, because we know that can affect the diaphragm muscles. So it can occur spontaneously during the active phase. There can be things that can trigger it. So things, again, like the other sort of triggers, surgery, infections, certain medications, as we're reducing sort of immune suppression. So the things you really need to be looking for, and the things that sort of we're all alerted to, is it can be quite quick. Typically, people would experience an increase in generalized or bulbar weakness. So rarely do you tend to get just breathing problems on their own. It tends to be affected by other things as well. So it could be severe dysphagia, which is the difficulty swallowing. So finding it really hard to get food down. Jaw and tongue can become very weak. You have a very weak cough. Might have difficulty clearing saliva, get a buildup of saliva in your mouth that you just cannot manage at all. Difficulty talking, so might end up with this very sort of nasal or slurred or very hoarse speech. Loss of sort of a gag. Your airway can feel blocked. People can often get a sort of report feeling like they're drowning or they're suffocating. And again, like with breathing, this orthopnea, so the difficult, so it's much worse. Your breathing's much worse when you lie flat. As I said before, with the breathing, it's so you would find with your speech that you'd have to be stopping sort of, regularly to take a breath in between words. Breathing becomes very sort of breathing at a high rate, but very shallow labored breaths, and using these accessory muscles. So often the skin around your ribs and like around your neck and your stomach can often pull in as you breathe, or this paradoxical breathing, which would be the opposite to what you'd expect. And you wouldn't be able to count over 20, probably not even over 15 in one out breath. So I guess the key thing of avoiding it is trying to recognize, knowing what the triggers are. So knowing what sort of things can make it worse and trying to avoid that. I know we can't change what the weather patterns do, but it's knowing that if it's a really hot day, really don't go out for a big walk at lunchtime, making sure you're trying to look after yourself as much as possible. I'll say it again, but just taking your medication now as they're prescribed. It may be that, again, if you're having identifying a relapse as early as possible so that we can try and get on top of it. And the advice that will be given will be very individual and tailored to depending on what's causing the relapse. But by getting on top of a relapse as quick as possible prevents the risk of it then becoming a crisis. So doing lots of things like we've said, eating healthy food, keeping your body weight down, keeping your muscles as healthy as possible, regular exercise, avoiding crowded places if you can, just to try or masks on, all the infection control things to try and avoid catching a cold or other chest infections, getting enough sleep and rest, try and find ways to manage your stress. But things like, if you're, I think we might cover that a little bit afterwards. We've got a few other questions we're going to go through, but things like if you're having surgery, make sure your surgeons and anaesthetists are aware of your myasthenia diagnosis. Is really important. But also there are, if you're not aware, the steroid sick day rules, which are how you manage if you do have the signs of a chest infection or particularly COVID, what you need to do with your steroid dose, because actually it's a way that you can manage that yourself as well prior to it getting to real crisis point. So I think the key thing would be of what you need to do is if you feel that you are struggling to swallow and breathe, you definitely can't count for more than 15 out of 15, and you're really struggling, then probably at that point it's 999 or you need to get some sort of urgent help or go to A&E. I would say if you don't have a specialist nurse, if you do have a specialist nurse, I'm sorry to all of mine who I work part-time, but the ones who the other nurses may work full-time, but also we probably don't work weekends. Again, it's trying to, if you can get help from either your neurology team in the first instance, trying to get their advice, because like all of us, we want to prevent you from going into hospitals as much as you don't want to go in. If you do need to go into A&E, I would always suggest take a copy of your clinic letter, your latest clinic letter, which will have a list of all your drugs, will have all sorts of things about, so people will know, but also they'll know which neurologist you're under. And take, I believe that MyWare, you've got some information on here about crisis as well. So, so it's worth just sort of having a look at that. Worst case scenario is if they do think you're having a myasthenia crisis, you may be taken to intensive care. Now, it's not necessarily because it's all doomed and they think, there's no end to it, but it's actually so that they can really closely monitor you, because what they're looking for is making sure you're not going to go into respiratory failure, and to see whether they need to get to give you some extra support to be able to breathe. They will give some of the emergency treatments like Georgiana said, so either plasma exchange, IVIG, probably start if you're not already on them, really high doses of steroids. Probably stop your pyridostigmine, which everybody goes, oh, hang on a minute, that's my go-to drug. But actually, because like I said, it can cause sort of excessive secretion. So they would stop that whilst during a crisis. Speech and language therapy would be involved looking at your swallow. So it's whether we need, whether you'd need a nasogastric tube, just so that you can make sure you're getting medication, but food and fluid as well. Recovery time really varies between one person to the next, so it's really hard to say. There can be lots of different factors, but as soon as you're stable, believe me, they won't keep you in intensive care any longer than you need to be. You'll be on the ward, and then again, once you're much better, then they will send you home. Sometimes if you're not on steroids and they need to start you on a really high dose of steroids, sometimes people can have what we call a bit of a steroid dip before it gets better, so they may keep you in for observation. So a couple of the other questions just around crisis. I think someone had said, what about rescue medication? So just going on from that. So pyridostigmine, a number of people, a lot of you will probably have started on pyridostigmine. We always advise our patients that even once you stop, or if you do stop pyridostigmine, always keep a bottle of that in your medicine cabinet, kitchen cupboard, wherever it is, handbag, because actually that's your go-to medication. If you start noticing that you're getting any change in symptoms, any worsening symptoms, that's your medication. You can just start that again. You probably don't need to taper up too slowly, depending on your symptoms. So that would be what I would probably class as your rescue medication that you can have while you're waiting to seek help. So start that, but then you need to speak to either your GP or nurse or neurologist. There was a question around how prepared should we be for crisis if we had a thymectomy and we're stable on medication. Well, if you've had a thymectomy and if it was a thymoma and they've removed the thymoma, sort of the risk is lower. And if you're stable on medication, then it's, the risks are lower. I think it's a really difficult one because we want people to understand the importance of seeking help early, but actually not panicking you. So there is always a risk of a crisis, but we don't want that to take over your day-to-day life. So you won't do anything or go anywhere because you're concerned you're going to have a crisis. I think the key take-home thing is just making sure that you do, as soon as you notice any change in your symptoms, it's getting help, getting on top of it as quick as possible. Even if you do get a response of no, it's fine, that's okay. It's just trying to sort of make sure that you seek help as quick as possible to prevent it from getting any worse. Okay, I feel like I've just talked for way too long, so I'm going to pass this back over to my colleagues in a minute. I'll have a breather. We had lots of questions, and we've tried to do it in the different categories of medication, fatigue, breathing, and crisis. But we did have lots of other really random questions. So we're probably going to just fire them back at you in a bit of a random order. So I'm going to start, and there were a few questions around what myasthenia nurses, how many of us there are, and how do you go about getting it. So at the moment, we have 6 just dedicated myasthenia specialist nurses, but we have many neuromuscular clinical nurse specialists who cover lots of different conditions, but they do cover myasthenia. So we're scattered all over. I'm in Southampton, Georgiana's London, with Sarah's Northern Ireland. We've got London, Glasgow. So whilst Caroline Carmichael in Glasgow doesn't cover the Highlands, and that's due to just limited access in resources, but she is available for general support and advice throughout Scotland. She may hate me for saying this, but she has said that is she is available for that. So if you feel that there is big need to get a clinical nurse specialist, how do you get one? So your neurologists need to write a job plan. I'm sure that's what's happened in most places, but it's the doctors that identify that. It's often done on, I know mine was specifically done around how to get people out of hospital quicker, and it's about preventing people from coming into hospital. So they write a job plan that is then submitted to the management structure. So it's putting pressure on your neurologist. The times to contact us, well, there's lots of different reasons why you might contact. So again, probably the key thing is any signs of a relapse or change in symptoms. But actually, we're here to hopefully support and advise you as much as we can when you're either first diagnosed or throughout your whole journey. We recognise things change at different points. It may be you've been started on new medication, you want to get advice about that, you're about to have an operation, you need advice. Often, I know one of the consultants I work with in clinic, to those of you who are on the line, you'll know who I'm talking about. But it can be quite a fast, quick clinic where you don't really know what is said until afterwards. And so often I'm there to then explain either at the time or maybe on the phone a few days later exactly what was said, and looking at sort of whether it's, you know, changing medications or things. You are able to ask for a second opinion. That was one question that we were asked, and you are perfectly within your right to ask for a second opinion. That can be even within the same service, or on the MyWare website there is a list of all the specialist centres, so you can have a little look and see what's on there. So one question we had is, what's the risk of ocular myasthenia developing into generalised? So studies show that it's about 1/3 of people will just continue to have just purely in their eyes. So unfortunately, the other third, so 75%, will then develop generalised myasthenia, and it's normally within the first 1 to 3 years. We have had our fingers burnt a little bit by that, you know, that's what we've always thought. A lot of the data shows that it's normally within the first 3 years. And I think we all take our foot off the pedal and go, okay, maybe it's just going to stay ocular. We unfortunately have had a couple of cases recently where it has progressed to generalised many years later. So it's always worth bearing in mind that if you've, for years, yes, you might be out of the woods and, you know, having to cope with just, you know, with your double vision or your droopy eyelids, but it may well be if you notice any changes in your breathing or your speaking or your sort of mouth and neck function or your upper limbs, then it could be that it's generalising. Somebody asked, is it possible to have myasthenia and MS, motor neuron disease, or Parkinson's? I would love to say, no, it's not, and that you only get one condition and that's all you're allowed in life. But sadly, unfortunately, there can be people who do get more than their fair share of conditions. So yes, you can have myasthenia alongside numerous other neurological as well as other conditions. There is help to be had from other therapists. So physio, occupational therapy, speech and language therapy. You may not have them specific to the service. So I don't have anyone specifically in the myasthenia service in Wessex, but there are general neurologists and community-based, there can be general services and community-based as well. And they can provide lots of support around day-to-day life. Your GP can often refer you to any of those. We also had a question around speech and language development in kids and teenagers. But all three of us, when we discussed it, we weren't aware that it would, you know, if you have myasthenia in childhood, that it will develop any speech and language. You know, it shouldn't be causing any problems, or not that we're aware of anyway. And my last question that I had before I pass it over was, somebody said that they had constant coughing in their throat to clear phlegm and a choking feeling. It's a difficult one. It could be to do with your swallow. I'd probably want to ask a lot more questions around what's going on around your chewing, your swallowing, trying to establish if that's more myasthenia. Is it anxiety? Some people can get a bit more of that anxiety, but also if you're getting a bit of build-up of phlegm, is there another reason? Is there something going on with your lungs that are causing the phlegm? So that question, I would say, would need to go back to your GP really to get some further investigation for that. And on which note, I think you're probably sick of the sound of my voice. So I'm now going to pass it over to Sarah, who's going to cover a few more little of the questions. Thank you.
Thanks, Jude. Thanks very much. I'm just going to go through some general things on travel, temperature, diet, pregnancy, and surgery. And we've kind of tried to go through all the questions that Jude has said and put things together in best ways. So advice traveling, things to think about before you travel or when you're planning. Have you got enough medication? have you got enough medication with you? You can put it in the hold or in your luggage, in your hand luggage, but we would generally say put it in your hand luggage because then it's safe with you. Do you need any rescue medication, as Jude had suggested? So you just need to preempt to make sure that you've got enough to make sure that you've got enough when you're there, but also that if anything else goes wrong, or if you're delayed flights or anything, or if you're delayed getting home, that you've got enough to carry you through. It's useful also to take a copy of clinic letters with you, just not that you can't fly or anything, but so that you have something with the last details of your last appointment, or who your neurologist was, or your nurse specialist, or a ways and means to contact somebody from your that's been looking after you. You can get emergency packs. And you would have like a little ID bracelet. So wearing an ID bracelet is useful, especially if you're away, or if you're just generally, if you're out and about. Carrying a steroid card with you, knowing what your sick day rules are. And another important bit of information that's available on the MyAware website is the specific drugs to avoid. And with all the best will in the world, you would think, or you would like to think, doctors, pharmacists, people that you might come into contact will know what you should be avoiding, but trust me, they don't, and they can't be really expected to. So I often suggest to patients, go armed with your steroid cards, your sick day rules, and your information about drugs to avoid, and wave them at patients and people furiously, so they can understand, what might be of difficulty for you. Consider what vaccinations that you might need. Are your vaccinations up to date? Are there any specific vaccinations for the country? Are they compatible with the medications that you're taking? Consider make sure you've got your holiday insurance. It shouldn't necessarily affect your holiday insurance, but if you haven't registered some of your condition, as with lots of things, that's a good excuse for the holiday insurance not to pay out if you haven't made them aware of a condition that you're traveling with. Also, minimizing a risk of infection. So what you're going to be considering, if you know you're going to visit somebody and they've got COVID in their house, then maybe rethink staying in that house with them. But it's about good hand hygiene that we all should have learned during the COVID times, and observing specific rules and regulations or recommendations when you're away. So not drinking not drinking the water, drinking the bottled water, making sure you're maybe not putting ice in your drinks, even though they probably say you can have ice. But there's just all the things that you would normally observe if you're going to a foreign country, then making sure that you are being careful, particularly careful. And again, minimizing that chance of infection to yourself. Optimizing treatments as well, making sure that you're not just saying, well, you just have my appointment with the neurologist and he's reduced my medications. I would be maybe suggesting people don't change their medications either way, up or down, before they're going on holiday, because we don't know what the impact is. There'd be no harm, particularly if you're reducing something, waiting or discussing with your neurologist or your nurse about maybe waiting until you've come back from your holiday, depending on the reasons for, or even delaying your holiday, depending on the reason for the increase or the change of drugs. You can get a sunflower card. I don't know if these were available before COVID, but they're like lanyards that people wear to show that there's a hidden disability. And there's a hidden disability sunflower website that you can go on, and it's a plastic laminated lanyard that you put around your neck, and people will understand that there's you don't maybe necessarily want to avail of the wheelchair facilities in the airports, or the assisted assisted travel, but these cards often make somebody alert that there's something else going on with you. They're not just specific for myasthenia. Following on from temperature, from travel, consider the heat that you're going to, or as Jude, if you're lucky to live in the south of England, you might get a bit of warmth. We don't get much here. So your myasthenia can be affected by extremes of heat, and you'll be the best person to know whether, you know, how much heat affects you. And it's just being simple. Again, there's lots of tips on the MyAware website how to manage yourself in heat. So making sure you've got plenty of cold drinks, if it's necessarily putting water in the fridge, wearing a hat, staying out of the midday sun. So the things that we would normally recommend, people should be alert for and be aware of the fact. I have a young girl who often goes on holiday and always has a relapse when she's on holiday. And I just want to tell her not to go anymore, but she can't really, you know, that's your own personal choice, but be aware that these things can happen. So understanding your triggers, as has been mentioned already. Again, the steroids and the pyridostigmine can affect how you feel. So they may make you feel warmer in general, and therefore more conscious of the heat. And the pyridostigmine can make people sweat more. So it's you know, again, having to manage those situations. Diet was another question that was asked about. There's no specific diet. It's just a healthy, well-balanced diet, making sure you've got plenty of calcium and vitamin D, especially if you live in, even if you live in the south of England. I think you need vitamin D. I don't think we get enough vitamin D to process the calcium that we need anywhere in the north of in England or Northern Ireland, Scotland, Wales, anywhere. So it's about making sure you're plenty of, and if you have to take a supplement, people are put on supplements if they're on the steroids anyway. But making sure you are avoiding or reducing your salt intake, which is generally good for us, good advice. But also reducing your salt intake when you're on steroids reduces any chance of increased fluid retention. Pyridostigmine can cause diarrhea and cramps in the tummy, and that can sometimes maybe put people off their food or make them feel a bit nauseated. And there are medications for this. So that it's useful to take, but also be aware that that's what's happening, and it might be a side effect of your medication. Pregnancy has been mentioned again, and it's really about, if you're planning a pregnancy, then discuss that with the team. As Georgiana said, there's just azathioprine as your medication. Often people find, and I don't know why this is, maybe somebody else might do. I'm sure somebody else knows. But in pregnancy, often your symptoms of myasthenia, you go into remission and you're a lot better. You do need to, even if you're feeling well and your symptoms of your treatment's been optimized before you have your pregnancy, you need to let your obstetrics team know, and the team that are looking after you know, because there can be issues. If you need an anesthetic, if you need if there's nothing specifically wrong with the baby, but there's very rarely babies can have some transient myasthenic symptoms, and the teams then need to know what they're dealing with. So it's about making sure that you have given over your past medical history accurately. And sort of following on from that, in terms of having surgery, people asked about surgery. Can they have GAs, local anesthetics? As long as your anaesthetist is aware that you have myasthenia and the medications that you're on, surgeries are generally fine. They will quite likely increase or double your dose of steroids or increase your steroids. And I think we'll go over some of the sick day rules after that. But your team would take care of that for you. And if you can, local sedation may be a little bit easier. If you're well and your myasthenia is under control, there's no reason that normal general anaesthetic won't work. It will work, but it won't be safe. But local anaesthetic is often, if possible, but I think that tends to be the general rule for most surgical types of interventions anyway. But again, the take home is just making sure that people understand that you have myasthenia and the medications that you're taking. probably rattle through that quickly. But I'm going to hand over to Georgiana for our last bit.
Lovely. Thank you very much. So, right, we had a few questions. First ones were about pain and if you should be experiencing pain with myasthenia. So, pain is not a common symptom of myasthenia. There could be other reasons why you have pain. So I would just go to your GP and discuss this. You could have arthritis, which is very common as we get older. And unfortunately, there's nothing really that we can do to, change that. Maybe exercise would help. But definitely go to your GP and ask for advice, especially if you want to try different type of pain relief. And then there was questions as well about receiving IVIG treatment and quite frequent infections, like we've mentioned. IVIG doesn't really suppress the immune system, so you would have to look into other things as to why you're getting these infections. If you do get frequent infections, then you can do blood tests and you can also go on prophylactic antibiotics to kind of prevent that. There was a question about bone density. So if you've been on the prednisolone for a very long time, you can develop osteopenia or osteoporosis, which is the thinning of the bones. You can then be referred to a bone clinic and they will decide on medication about bone treatment basically to keep your bones strong. So I won't be able to say which one specifically is the best for you, but there's definitely a choice there, and your GP can refer you, your neurologist can refer you for that. Also side effects from the steroids have caused diabetic retinopathy. So we would say, can you basically reduce your steroids? The only kind of way to not make things worse, I guess, would be to try and reduce that. If you are not able to reduce your steroids, you should really be on something else, on another tablet, like the ones that we spoke earlier, like a steroid sparing agents. There was a question about neck ache. So again, a little bit tricky if we're talking only about aching and where you're not actually experiencing a head drop where like your chin would be all the way to your chest. It could be that's a bit of arthritis in your neck and it just comes with age. But if you do experience the head drop and you have like swallowing problems, then definitely get in touch with your neurologist. Otherwise, just look into physiotherapy and try some pain relief, see what works. You can again go back to your GP. Questions about when you are in remission for many years and kind of the only you only had fatigue, and now you're getting older and you have a lot more fatigue. Do you need medication for that? We, like Sarah said, we don't really use a medication to treat fatigue. If you're experiencing fatigue at that point, then we would look into other things. Sometimes when you are when you have like deficiencies in vitamins, so vitamin D, vitamin B12, then you can experience fatigue. So you would have to discuss with your GP and look into other causes. If you have fatigue and some symptoms of the myasthenia are coming back, then definitely get back to your neurologist to discuss this. There was a few questions about COVID. So if COVID vaccines have caused flare-ups of myasthenia. So again, quite tricky to answer this question. I think a lot of people are quite worried about getting the vaccines for the COVID or any kind of vaccines. We always advise to get the vaccines because if you are taking medication, you are immunosuppressed and you are at the high risk of getting like flu and COVID. And having COVID would be way worse than you having the vaccine and having a relapse. Well, in my experience with my patients and the ones that have developed COVID, they were quite unwell. So I would really try to avoid getting COVID. So I understand, you being reluctant on getting the COVID vaccinations. I don't know how you would be able to kind of manage that preemptively, but have a discussion with your neurologist, see if there's kind of what kind of ways you can do to mitigate that risk of having a flare-up. There has been some reports, I think, in the literature suggesting that there can be some flare-ups, but it's not specifically tied to the myasthenia. I think any kind of autoimmune condition could potentially flare up if you had the vaccinations. If you do test positive for COVID, there are antivirals that you can have. You just need to ask your GP for a referral to the unit that delivers the medication, the antivirals. How do you know if it's the drugs that help or are you in remission? So there's really not really a way of telling that unless you start reducing your medication. What we are aiming for is for you to be in remission, usually in pharmacological remission, but I wouldn't really start reducing, by myself. Just speak with your neurologist, have a conversation and see if you've been in remission for many, many years. You can definitely discuss of reducing that. I think there was a question about aching limbs and muscles, muscle wastage. Does this reduce? If you are not moving around and you have aching limbs and your muscles are wasting because you're not moving around much, very unlikely that this will reduce. This will most likely get worse if you continue. You need to try and keep as active as you can. Keep moving around even if you feel absolutely exhausted. Try just to do a little bit each time. I know it's difficult, but it will just keep getting worse and worse, like what Sarah mentioned already. And I think I'll get back to Jude because he would like to talk about sick day rules.
Yeah, hi. I'm just aware that I've mentioned steroid sick day rules and Sarah has as well. I think we probably all have. So we've just had a few questions come in about that. So what I'm going to try and do, if my technology allows me, is share on my screen. Is that sharing? No. Oh, they are. I need to click the share button.
There we go.
Is that on?
Not as yet.
Not as yet. Okay, right. Let's try again. There.
Oh, we're moving. We're moving.
We're moving. Okay.
We're there.
So,
we're a bit small, but we're there.
Okay. I don't know if I can make that any bigger.
Plus button at the top, middle top, on your ribbon.
That one? That one?
Just the middle. There you go.
Is that big? Okay.
That's big.
What you need to do is you can type into Google, if you have internet access, steroid sick day rules. And these ones are the ones I tend to use. I think a lot of my colleagues use these as well. It's from the Society of Endocrinology. So it's basically, there's some very basic rules. And I think the key thing is so what happens is your body normally produces steroids. So you have these adrenal glands and they produce steroids. When we give you high doses of synthetic steroids, it's almost that they switch off and go, well, I don't need to do anything now because, the body's getting a source of cortisol, so of steroids, so I don't need to do anything. So what can happen is if you become quite unwell, your adrenal glands don't produce enough to be able to cope with you being unwell. It's also another reason why we try and when we reduce steroids, we don't just suddenly say, right, and now stop, because you need to go down slowly. So the sick day rules are basically, the key thing is if you've just got the slightest cough or cold, little bit of hay fever, a bit unwell, don't change your dose. This is only if you are really unwell with a fever. That's the key thing. It's an infection, because actually the risk is that your body then won't be able to produce enough to cope with the demands that that it needs to be able to cope with you when you're unwell. So on the second page here, there is a little bit at the bottom that says about the steroid adjustments. Again, I would, always, they're useful to have, but you know, talk to your neurologist about this as well anyway. But I guess the key thing is it's more around not taking them at the signs of the slightest cold, but it's more if you're actually quite unwell and you've got a chest infection, or you've got a urine infection, but also there is some advice again around sort of dental surgery or just normal surgery. Again, it's always worth just double checking with your neurologist before doing that. So I'm not saying you have to completely go by these, but actually they're very useful things to have, especially when you're going away. And it says here at the bottom again of making sure that you carry an emergency card. So hopefully that just covers. I will just show you the top page again. So it's steroid sick day rules, and if you just type that into any Google search, you can print yourself off a copy if you can, or have it as a somewhere to refer to. I'm going to stop sharing that now. And Tracy, I think I'm going to hand it over to you now. I think we've probably all covered everything. I think we've probably talked for a bit longer than we should have done, but that's
all
us.
I can say, ladies, all I can say is wow. Honestly, thank you so much. I'm sure everybody agrees that's an incredible session. Lots of helpful information and advice. And we as a team, we learn more every time we meet with the nurses, and today is certainly no exception. So thank you. You've given up your time to join us today, and actually you've made this possible. Sharing your knowledge and expertise with us is so helpful, and our members. I know you wanted to reach as many members as possible, and we know you're a rare commodity. You are a 6, but today you are a 3. You've done a lot of preparation before today. So again, thank you from us all at MyAware, and thank you on behalf of all of our members. Very much wanted to just mention, many of you donated before today's session, actually, which was lovely. So thank you very much. We know it's not always possible, but if you have enjoyed today's session, you are able to make a donation. You can do so using the QR code on the screen, or you can go to our website and use the Make a Donation button there. It's our final push for My Awareness Month, so we are a little bit needier than we normally are. We are really trying to get a good total for this year's My Awareness Month. And finally, a thank you to you all for joining us today, our members. I hope you found the session as valuable as we did. We look forward to seeing you at some more upcoming sessions that we've got in the pipeline. We will be sending you out an email after today with any of the links that we've spoken about, the lanyard, sick day rules, those sorts of things. But obviously, as the nurses have said, always speak to your GP or your neurologist before you make any changes or any different decisions with that. There'll also be a link for the survey in there. And of course, we love having your feedback. You can also send it to our email address, which is support@myaware.org. I know many of you know that, but it's lovely hearing that you're enjoying what we're doing. It's important to us to know that you're enjoying it. So thank you for those in advance who will fill that survey in for us. It is very much appreciated. We did have some questions in today, and today's session was based around questions we received prior to the session. So thank you for all of those. You've obviously created today's session with the nurses as well. For those that sent in a question today, pop them over to email to the support email address, and we'll do our best to help you from there. Laura, I think we've just got one more slide to pop up, and apologies if you didn't see me at the start. You didn't miss anything, I promise. But literally, that's all. Our thanks, I think, for today from the team at MyAware, and to you for joining us. We look forward to seeing you soon, and we will be ending the webinar very shortly. Thanks, guys.